Okay, guys, so let's get into it. Earlier today, I posted a video letting you guys know that I had a new client today for my telehealth practice and that I would probably let you know the deets later. So, this is my Let's Talk Skin. So, Let's Talk Skin, Tinea Versicolor. So, um, essentially, I had a new client today, is a 51-year-old male, is complaining of a rash that he's had for several years. Basically, the rash kind of comes and goes. A lot of times it is made worse by heat and sweat. And when he's outside cutting the grass, the rash is a little bit raised, but mostly flat, and it's causing discoloration to his skin. He said that in the past he had used Selsun Blue and he was prescribed a medication called ketoconazole shampoo by his primary care provider, which he hasn't been using and hadn't had in a long time. So over the last several weeks, it's just been getting progressively worse. And so let's pretty much get into it. So what you're looking at right now is my favorite, I guess you can say, reference, which is visualdx.com. It's essentially a library of most skin conditions, and they have a plethora of visual images, especially since COVID, when we know the disparities amongst people of color and things like that. They recognize that there needs to be a larger collection of images of skin conditions in patients of color. And so I like this particular reference because they have lots of different skin presentations in people of color, but not just people of color, people of all ethnicities. So the key things you need to know here is in dermatology, we usually talk about Fitzpatrick skin types, usually have Fitzpatrick skin types 1 through 6. And usually skin type 1 is pretty much your very, very light skin patients, and Fitzpatrick skin type 6 is your very dark skin patients. So the key things you need to know about Tinea Versicolor is very common, especially in warm, moist, humid climates. It typically will come and go, which means it's basically recurrent. It's not usually persistent, but if it's not treated, it can be it can kind of overgrow and kind of become essentially like very extensive. Typically, patients will complain that it presents itself during the warm, moist summer months, and it's usually asymptomatic, meaning that it's not necessarily itchy, but it can be. So let's take a look at some of these pictures we have here on the side. So starting here, you can see essentially talks about kind of like where you would expect to see this rash. Usually you'll see round configurated plaques on the skin, and it's usually sort of like a patterned. When it says hypopigmented macules, that basically means white patches, white flat patches on the skin. Hyperpigmented macules usually means darker patches on the skin. And so usually you might see a fine scaly plaque. And in dermatology, plaques mean essentially something that is not flat to the surface, like a macule. And a plaque is a little bit more raised. It has a border, it has scale. Okay, so that's the first thing you need to know. And then it's usually located on the neck and trunk, but I typically tend to think people that have a history of dandruff, they typically colonize the type of yeast that usually causes this condition to exacerbate. It's called Malassezia furfur. It's super common. It's usually colonized on the scalp. And if that condition is not under control, sometimes it can also proliferate onto the other body surfaces, usually your chest, upper back, and trunk. So as you can see here on the back of this person, you can appreciate that there's some discoloration. This is probably a Fitzpatrick skin type 4, meaning that it's not on the one spectrum where it's like really dark skin and it's not really light skin. You can see where the rash is. You can see and note that there is some erythema, which erythema is essentially means like redness on the skin. And in this skin type, you can appreciate this redness. But if this was a darker skin type, like a Fitzpatrick skin, type 6, you probably wouldn't see it as much. It would probably show up more as like a hypopigmentation. So you can see that there's like these like little patterns, these little islands in between this normal skin and the redness, where you can kind of see that you have this pattern rash. And then if you look here, I think it's like very classically kind of like how it presents. So you can kind of see these macules like we talked about. You can't really appreciate the scale on here. And when I say scale, I mean like, like kind of like dry, flaky skin, but you can see how it's very patterned and is typically on the predilection sites of like your upper torso. Here's just a closer image of those hypopigmented macules that I talked to you about. Macule meaning it's a certain size, usually less than 0.5 centimeters, and it's flat. You can see that it's very well patterned. Hypopigmented meaning it's white. Here you can see it on the side of the neck of this African-American male. This is probably more of a Fitzpatrick skin type 5. And you can see that it's in that predilection site of like the head and neck area. Sometimes people may confuse this with like a ringworm. It's still a tinea, meaning it's a dermatophyte infection. Tinea versicolor, tinea corporis, tinea curis, tinea unguium. Basically, tinea meaning a dermatophyte, a fungal element. Tinea corporis meaning ringworm, the medical term for ringworm. Tinea unguium meaning basically a fungal infection of the nails. Tinea curis meaning a fungal infection of the of usually like the genital area, so to speak, like a jock itch or something like that, or underneath the breast. Tinea capitis, like in young children, you would see like when they have ringworm of the scalp. Those are typically how they are described in dermatology. The first part is the organism or the type of infection, and the second area is the location of the said infection. Here you see it a little bit more. You can appreciate the erythema, and this client is probably a Fitzpatrick skin 4. You can see that there is some scale where you can see kind of like a little bit of desquamation in the center, but you can see it's very well patterned. So I'm not going to go through all of these pictures. This one definitely is a lot more scaly. You can appreciate this kind of like rim of scale right through here. And you can see it's like creeping on the neck, and it is very inflamed. So this person may complain of itching and they may not. Here again, you see a good, pretty presentation of what you would expect to see in people of color. You can see it has some follicular prominence, meaning, you know, your hair follicle. You can literally see the little circles within the circles, and that just means it's coming, it's prominent through the hair follicle. So this person, you may want to consider treating with like an oral antifungal, just to be on the safe side. Sometimes if this rash is treated with topical corticosteroids, like a hydrocortisone cream or something people use over the counter, it can kind of drive that fungal element, that yeast, that deeper into the hair follicle and make the infection essentially harder to treat. Here you can't appreciate it so much, but you can see you have more of that violaceous color, and this darker skin type is probably still a Fitzpatrick 4, more likely a 5, but you can see how it presents on this person's skin. It's more violaceous meaning like more purple. This is a really good one. Wow. Okay. So look at this. It's like all up here on the arms. It's spreading here on the back, what we call centrifugally. So it's coming out almost in like a Christmas tree pattern. And this is pretty classic for Tinea Versicolor. You can see this person has a lot more scale than some of the other ones. You can see this discoloration of the skin, which I will tell you is not permanent. Okay. So if you have this, people always ask like, will their skin color come back? It will. It's just, this is what's affected by the malassezia. It's kind of like what's causing that discoloration. And so as this gets better over time, you're going to see your skin color come back. Now, this person, I would most definitely treat with an oral antifungal. This is really extensive. So this person, I would just make sure they didn't have like really any chronic liver conditions or anything that I was concerned about. Typically, oral antifungals will usually metabolize in the liver. So you just want to make sure they don't have any like chronic history of liver disease, like most notably like a hepatitis or something else that may cause a potential problem. Most of the time, the oral antifungals are safe, so you're not really going to be overly concerned about it. So this patient I probably would treat with oral fluconazole, 150 milligram tablets once weekly for probably about 4 to 6 weeks. Here again, you see the front side looks pretty extensive. And this is what you actually would see under the microscope. So this is what they call a KOH prep. Basically, you're looking for fungal hyphae and spores. And as you can see, there's a lot of fungal hyphae and spores. Essentially, the patient would come into the clinic. We would do like little KOH prep. So I'd take a number 15 blade and do like a light scrape of the skin. It doesn't hurt. And we would mount it on the microscope slide, and we would use a little bit of KOH, which is basically potassium hydroxide, and essentially like eats away all of the stuff that you don't need to see. And we, well, at least I do, use a lighter to kind of heat it up. Basically, it eats away all the stuff that you don't need to see. And then you get this, the positive stuff, fungal hyphae and the spores. So the fungal hyphae being like these branches that you see, and then the spores being like these little dots. Classically, we call it spaghetti and meatballs. If you see spaghetti and meatballs underneath the microscope at a KOH prep, it's positive for tinea. This is on a more lighter skin patient. You can appreciate the difference here, right? So you don't see a very stark contrast, but you see a contrast. You see probably a Fitzpatrick skin type 2, not super pale, but definitely more lighter skin. And you can see it's a little bit more red. You can see it's definitely a little bit more raised. And I would say it's probably pretty extensive. So this one too probably needs some oral antifungals and some topical ketoconazole shampoo to wash the body with several times a week. Okay, one more, guys, and then we're done. Okay, again, very inflammatory. You can see the scale. You can see how well patterned it is. It's very discrete. Some of them are confluent, and confluent just means they kind of run together. So you can kind of see up and through here. And then you can see the scale. There may be some slight follicular prominence you can kind of note in through here, but for the most part, I would say this is pretty inflammatory. This patient may have some complaints of pruritus, which is a medical term for itching. And so you may want to consider giving them something for this topically as well as orally. Here's not so much. Here again on darker skin, probably Fitzpatrick skin type 5. And here probably Fitzpatrick skin type 4 or 5, pretty extensive. You can see how it's raised up off the surface of the skin. So these are those hyperpigmented plaques that we talked about in the beginning. Okay, guys, so that's pretty much it for this. So Tinea versicolor in an adult, very common, also known as pityriasis versicolor. It's a benign, non-contagious, superficial fungal infection of the skin. Typically, the infective organisms are the Malassezia, like I said, the Malassezia furfur. It's a yeast. It's part of the normal skin flora. Typically, people may have a concomitant condition of seborrheic dermatitis, a medical term for dandruff. So that's something to consider. And if somebody has dandruff, it typically can affect like their outer ear area, the inner ear area, their eyebrows, and around the nasolabial fold. For men, definitely the beard area. So the hairier they are on the face, it may present there, and definitely in the center of their chest. The distribution is worldwide. So this is a condition that you see kind of like all over the world. Again, not contagious. Factors mediating its development: heat, humidity, oral contraceptives, deceptives, corticosteroid use, topical corticosteroid use, oral as well, and immunosuppression. So if you see a patient that has a chronic condition like this, and it doesn't seem to be going away despite you giving them topical antifungals, oral antifungals, and it still continues to persist, you probably want to do a workup to make sure they don't have anything else going on, especially probably like an HIV. For sure, I would probably run an HIV test on that patient if I was having trouble with this. So usually begins during or just after the warmest months of the year, and it may last from weeks to months. There are no associated systemic signs, meaning people aren't going to have like nausea, vomiting, fever, chills, anything like that. And it should be in your differential diagnosis. So in dermatology, I always talk about differential diagnosis. So my differential diagnosis would be tinea corporis for sure. You may even consider like a plaque psoriasis or nummular eczema, but there are differentiating features for each of those, which I'm not going to get into right now. And here you go. So your differential diagnosis that we talked about, CARP, definitely, that's something we could talk about later on. Erythrasma is caused by the same organism, Malassezia furfur. We're not going to talk about that. Sebderm, like I talked about, dandruff, tinea corporis, like I talked about, ringworm, atopic dermatitis, another form of fancy term for eczema, but very specific. We could talk about that on another video. Pityriasis rosea, again, something you could consider, but you have all these things. Nummular dermatitis, as I said, nummular eczema, you could consider that. Mycosis fungoides, definitely something we should talk about. This is actually cancerous lymphoma of the skin and can lead to actual internal lymphoma if it's not treated. So that's a very scary condition, and definitely is something to be worried about if it's not getting better. So some of the best tests we talked about: doing a KOH prep, and recurrence is common. We're going to treat it with ketoconazole shampoo and oral antifungals. So there you have it. And it was nice talking to you guys. Thanks for listening to me on my Let's Talk Skin series, and we'll do this again next time. All right.